thank you very much, and thanks the organizers for having this opportunity to come back to Korea, to come here once again. It's always a delight to come and visit and learn so much from you. Today I'll talk about precision medicine, the initiative that we are part of in the United States called All of Us, and also how to promote use of healthcare data. There's much to be said about medical AI and how it learns from medical data, and I think the more we can disseminate the data with a degree of privacy for the participants and the patients, then that will be a great advancement. So, biomedical informatics and data science has many subspecialties, and I grouped some here according to my view of our field, but there are many other ways to slice and dice the medical specialties involved. And I put in yellow font here the practical precision medicine and the foundations for precision medicine, because those are the two things that we as informatics experts have been contributing a lot to precision medicine initiatives, and I'll talk a little bit about those in here. Yesterday I spoke to another group about data privacy and how we can do data sharing and also protect the privacy of patients at the same time. Also on how we can collaborate even though we may maintain data in different areas. So I see ourselves having influence on how the data are collected for this cohort studies, and I'll talk about the All of Us program now, about models, how we use this data to build AI models, to build statistical learning models that can do predictions, that can estimate certain quantities, and then we use that in the practice of medicine. And as implementation as well, because we cannot do all of that and then not apply into clinical practice. That would be something always missing. And when we do that, we need to be very careful about validation, about performance metrics in the population where the model will be used, and then consider the model the same way as a medical device, that it needs to be constantly evaluated. It may be recalled, and it may need to update, and so on, because it does change care and it changes outcomes. What is the ultimate goal anyways? So what does precision medicine do? What kinds of data? And the interesting about precision medicine, the very fascinating aspect, is it goes through all the levels. It deals with the molecular level, with the cellular level, organ systems, people, and populations. So in the end, it's precision medicine, personalized medicine for one individual, but you need to have this large population in order to do more precise estimates. It has to do with health systems, with hospital and clinics, and it has to also do with networks of systems. So let me talk a little bit about a related project, and this is a Center for Excellence in Genome Science, funded by one of the institutes of the National Institutes of Health in the United States, and we named it the Center for Admixed Science and Technology, CAST, Genomics for Everyone. So just as a preface to what I'm speaking about, in the end, we want to use genetic findings in clinic, right? But I give here an examples of underrepresentation of populations that led to incorrect conclusions about certain variants. For example, hypertrophic cardiomyopathy variants were said not to apply to certain populations, as opposed to the original article. So when this variants were considered in African American populations, they were shown not to be associated with this condition. Hearing impairment was another one in which a certain gene was believed to be important for that, but when analyzed in African Americans, in African populations, it did not hold. So as you can see, if there is underrepresentation of certain populations, you might discover things that are not universally correct. So many genome-wide association studies, GWAS, had findings that had to be corrected later because they were shown not to apply in general to the population. So again, if we are to do precision medicine, that's even more important. It's not about a population, it's about an individual. So accounting for admixed population structure is another thing that is important for these discoveries, but it's rarely done because it's difficult to be done. And in the end, everyone is admixed to a certain extent. So the definition of who is admixed or not is not a threshold, it's a continuum. And what happens is admixed population, the more admixed it is, the more power you have for variant discoveries and portability of your models. So we want to operate with this data, but it's not easy to do. And because it's very admixed, you need even more samples, even more individuals to be genome sequenced. So polygenic risk scores is a fundamental part of precision medicine, and they are to predict disease onset, progression, or treatment outcomes. And how do we do that? Well, we need a whole lot of data because we need to genome sequences of a whole lot of individuals. These models are currently mathematically very, very simple. So they are not AI models, deep learning, or anything. They are regression models because we don't have enough data to build more sophisticated models. The data are continuously being generated and recorded, but not necessarily used. So that's something we need to correct as we go with these initiatives. The polygenic risk scores, so the estimates of these models, they needed to be continuously evaluated because otherwise we would have that problem of not being relevant to certain populations or to certain individuals. So can we avoid introducing biases and protect privacy? So again, if these models are built using training sets from one population, but then applied to another population, we actually need to be very careful because medicine is about first do no harm, and these models can actually do harm if applied incorrectly. So what to do with individuals from mixed ancestry? Is it fair just to exclude them from all this analysis and therefore to exclude them from the estimates as well? And the answer is certainly no, but how can we do this in a way that everyone is represented? So our vision is we should leave no one behind, that the current concepts of race and ethnicity, these labels that are frequently used in describing demographics of a population, they probably can be replaced with more objective variables. For example, the genetic findings can replace certain aspects of the label race, for example. Ethnicity is a whole lot about cultural variables, and those can be replaced too if these environmental variables, cultural, diet, and exercise are all included instead of a generic label that does not represent all individuals with that so-called ethnicity. So we also have phenotypic data and social determinants of health, which may end up being the most important variables after all in the maintenance of health and then also in the treatment outcomes. So we want to develop methods that include all these variables and also allow the genetic findings to be applicable to all, unlike they are right now, because the GWAS are mostly based on European populations and therefore don't apply to everyone. So the disease risk models, just as a schematic here, a particular trait that we're studying, for example, cholesterol, cancer diagnosis, and so on, is a function of genetic determinants and social determinants. Within the genetic determinants, there are variant effects, the variants that happen to your genome, as well as ancestry aspects that have to do with your inherited DNA. Then there's social determinants. As I spoke, there are environment, income, education, diet, access to healthcare, and a whole lot of other things that are very important in determining health, in addition to genetic variants. So we want to do this using algorithms and tools that analyze data, and because many of those variables are stored in databases that cannot be moved and data that cannot be moved around, we have to develop algorithms that can go access this data, do the calculations, and never move the data outside of their places. And that's happening right now in several projects. So again, in our center, we're trying to understand polygenic risk scores that are ancestry aware and are not ancestry aware in terms of determining a global ancestry, but utilizing segments of the DNA and saying this segment came from this ancestry, this other one from that other ancestry, and then calculate things that way. It's not about just single nucleotide variations, but also structural variants. So tandem repeats, duplications, deletions in the DNA, all of this need to be taken into account. HLA analysis, HLA is a very complex region of the DNA, also needs to be analyzed in particular ways, in more fine-grained ways than it's currently being done. Social economic determinants of health, again, a very, very important aspect. How to do this while preserving genome privacy, preserving the privacy of individuals is another topic of importance, and how to do this distributed analytics. How can I compute with databases that are located in 3 different servers and still get my global algorithm to work? So polygenic risk scores and AI models will require a lot of data, and that's what we need to do. We need to build access to large data repositories in a privacy-preserving manner, and we need to aggregate data from different countries to use for new analysis, because no single country will have the representation that we need in order to be more generalizable and applicable to all. So we need to provide tools that integrate and analyze data. I have spoken yesterday for another group about how we did clinical data networks since more than a decade now, in which we use this distributed analytics in order to compute with data from many different hospitals without moving this data around. We started with the University of California system and then extended to others, including the Veterans Administration system in the United States, which is the one that has data from a large portion of the veterans in the country. And we were able to do analysis, including during COVID, we were able to quickly organize ourselves to answer some questions that were happening and no one knew exactly how to handle these patients in the beginning. So we also had an institution in Germany participating, precisely because we didn't need to move data around, but we didn't move the analysis around. So in the very beginning of the pandemic, to assemble enough cases to understand certain aspects of the disease, it was very important for us to do that. So we had a website in which clinicians could ask questions, and we would see if those questions could be answered with data from the electronic health records. One example was in here, in which in the very beginning of the pandemic, there was question about use of ACE inhibitors as antihypertensive therapy because potential interactions with the SARS-CoV-2 virus. And it was concluded from our initial analysis and then later confirmed by other people's observational studies that it was very safe to continue to have people take ACE inhibitors as opposed to what was hypothesized as being potentially harmful in this and others articles about that came about. But you got to understand that in the beginning of the pandemic, no one had that evidence, and therefore we had to go back to the electronic health records of several institutions, 10 institutions, in order to have enough power to answer the question. So now talking about the All of Us program, which I know you want to hear about, is the precision medicine initiative that started with the Obama administration in the United States. And the goal is to have 1 million participants, volunteers for that program, and combine that with another initiative, which is called the Million Veteran Program, which is also targeting to have 1 million veterans and have the genomic data as well as electronic health records and a biorepository available. So with 2 million, obviously we're better off than with 1 million alone, but I bet you even that will not be sufficient in order to build very accurate models and generalizable models. And what happens in this two program is very clear, was from the beginning that the data would never leave their compute enclaves. No one would be allowed to move this data to another server to compute, and therefore all analysis had to be done locally for both the MVP program and the All of Us program. However, we did propose to do federated, secure federated algorithms, and that's my colleague Hyung-Hon Cho, who has developed his career in terms of finding secure multi-party computation algorithms and encryption and things that can be done this way. So the goal here is we would do the very same analysis we would do with just one database that were local, but we will decompose the analysis, submit to two different compute enclaves, and get an answer that is shown to be the same as if we had accumulated all data in one server. So there are several techniques for that I won't go through today, but it's part of what we informatics experts do. So it's called distributed analysis, and I put here is what we call horizontal partitions, is because each one of those programs has the same kind of variables, right? The demographics, the phenotype variables, and then the genome sequences as well. And again, there are these partitions that we never put the data together, but we can compute with 3 of them here, the All of Us, MVP, and the UK Biobank. So the All of Us research program, just going into a little of the variables that are in there. We are a recruitment center for it and participate in several activities. So the kinds of questions that this program, this precision medicine program, may help answer are shown here, and this is a slide from the All of Us research program as well as many others that I will reproduce here. It's like how may we prevent the chronic pain that affects more than 100 million people across the US each year? How can we slow or potentially stop different kinds of dementia, and the other examples in here. So very complicated questions will require a lot of data to answer, but the start is to have these programs be launched. So we want also to support health equity. Will these programs like this help with that? So the innovative aspects of All of Us are the diversity at the scale of 1 million people. This is not a random sample of the US population. It's a sample specifically targeting populations that were not represented in research before, and therefore are harder to reach, but will provide much more diversity in, like I mentioned, the admixed populations as well. The data types that are collected are clinical, environmental, genetic, behavioral, socioeconomic. And the focus is on participants as partners, is to be on a more equal level than traditionally clinical in biomedical research has been, in terms of being very parentalistic in terms of the experts knowing everything and the participants just taking that as a given. And in fact, to get rid of that notion and make partnerships as opposed to that hierarchical relationship. And it's national, it's open for all, it's open to the public and all researchers, open source software and tools. And again, it's recently starting to be open to international researchers as well, and should be a source of data for everybody. Now, what are the potential activities asked of participants in the current protocol? So they enroll, they consent, they authorize electronic health records from their healthcare institutions to be transmitted to a local, a central repository for the All of Us program in the coordinating center, which is housed at Vanderbilt University. The participants also answer surveys about their health, about mental health, about habits and other items. Then they come for a visit where very simple physical measurements are done with blood pressure, heart rate, height, weight, hip circumference, waist circumference, and BMI is calculated. And then they donate biosamples. Those biosamples are blood, saliva if blood draw is not successful, or if it's done remotely, that the kit is mailed to somebody who lives in a remote location. Urine biospecimen, it's not a clinkage, it's just a regular urine specimen. And then these biosamples are stored in the program's biobank, which is housed at Mayo Clinic. There's a small portion of the population that also contributes data from wearables and digital apps, but this is a much smaller, less than 10% of the samples. And again, there's a lot of emphasis on having a diverse population for this. All of us consortium members that are here, this is the participant center, a communications and engagement group, and then what's called the healthcare provider HPO network. It's where we are one of 10 consortia that includes several medical centers. In our case, it was the University of California, plus other California institutions. Cedars-Sinai is a very large hospital in the Los Angeles area, and USC also has a very large medical center in LA. And like ours, there are other consortia as well, each recruiting what's about 1/10 of the population of the full million. So we actually, I need to update this slide. We are about 60,000 participants from California are participating in this. And then there are, as you see, other regions of the United States represented, as well as a program that again mails and does independent from a healthcare provider organization. But it's a very large program. It started more than 7 years ago, and it has evolved its protocols, and the whole operations are very, very large scale. So the California Precision Medicine, in particular, there are recruitment operations at 6 main California institutions. Each one of those has different sites, so different clinics, different affiliated hospitals that have a recruitment center that people can come for visits in there. And then again, there is registration, there is consenting, and so on. Biospecimens as well, and I put here the 80% of the participants are currently underrepresented in other studies. So there is a whole lot of emphasis in reaching out to hard-to-reach populations. And then there's the issue of retention, because many of such studies, you are successful recruiting and doing the first visit, but then the patients lose interest, so the participants lose interest, and then you don't have a follow-up in that. So we are, again, very focused on having retention of this hard-to-reach, hard-to-retain population so that there is more representativeness in the sample. And we have 2 types of retention. One is called active, in which the participants actively interact with a survey with some answers that are posed on them, or passive retention is the simple act of having their electronic health records submitted. So the participant does nothing, but by virtue of having records that are constantly updating in the healthcare provider organization, the program is receiving those records and using them for the program. Now, what does precision medicine and all of us do? They enable research discoveries that drive more precise approaches to care. And I must say, it took a while for those data to become available because they needed to have curation, they need to be cleaned up, they need to be presented in a way that others could use. And as I mentioned before, because the data have to stay in a compute enclave, that whole infrastructure to have researchers be access controlled, be registered, be trained in how to use the data took a while to be developed. But now it exists and in a cloud, and researchers can and have been using this to a large extent now. So again, here is another depiction of the program with the emphasis on easily accessible to any research with a secure internet connection. So again, you compute by logging in to the cloud, finding the data that you need there, finding the tools that you need there, and doing your own Jupyter notebooks and your own analysis, and hopefully contributing back to the program as well. Now, bringing together a diverse cohort of researchers now. So remember I talked about the diversity of participants and how it's important to have different data in this programs, but it's also important to have researchers coming from different perspectives in here, different medical specialties, different demographics, different interests in certain areas that of health equity, for example, that just people think differently, and this is important to have. How to ethically use the data, how to return value to the participants, and how to accelerate research impact are all in our minds at this point. Encouraging student assemblies and early stage investigators to bring fresh new ideas, that's also important. And then ensuring access for researchers from various institutions and organizations to establish a truly equitable resource for all. Because there is, in the United States, high diversity in terms of resources from institutions that have a lot of compute expertise, a lot of human expertise on how to analyze the data, to other institutions that have less so, and again have been unfavorable because they cannot have the same cloud compute power and so on. So we believe that by getting access to a cloud environment, a sophisticated cloud environment, that these researchers will have more chances now of being publishing work at the same level as their wealthier counterparts. So the All of Us research program too has a lot of communications emphasis, marketing, company specialized in this that has been hired to do a lot of the communications for the program. And again, I mentioned the California Precision Medicine Consortium that I still co-lead, that I started with the UC San Diego portion, and then we expanded to a region in the purple at the bottom here called Imperial Valley. It is a very poor area of California that we were able to recruit in the El Centro Regional Medical Center. And we also have other centers at UC Irvine, UC San Francisco, Cedars-Sinai, USC, and UC Davis, that's in the Sacramento area. And from those, we have been expanding as well. So with my move to Yale and Connecticut, we also opened expansion sites in New Haven, where Yale is, which is an underserved area for the population. 25% of the population of New Haven lives under the U.S. Determined poverty line. And also we expanded to the territory of Puerto Rico, in which 43% of the population is considered to be on the poverty line, and also is of the Hispanic demographic is predominant. We have done partnerships with churches, with other community-based groups in order to demystify what clinical research is and how it's important for people to be represented in these studies if they are to benefit from these studies. Now, the research hub components that you might be interested, because at some point you will have access to this data as well. Currently, the public data browser is available to everyone on the website. Data snapshots, survey explorer, and the help desk. But for informatics audience, I think you will be more interested in the restricted areas, the researcher workbench, in which there is more details, the data dictionary, the concept set selector, so you can select a subcohort that you want to work with, and then notebooks and the help desk. There is a so-called data passport model in which researchers are approved to use this data after some training online. And I must say that the notebooks and the programming languages are Python and R currently. And then, like I mentioned, Jupyter notebooks are used in order to record all your work. So examples of some initial All of Us publications. This is from my colleague in ophthalmology, Dr. Sally Baxter. Again, the possibilities are endless. You just have to have a good idea and then get to understand the data and then do your analysis in there. And those two examples are from phenotype data analysis, but they're increasingly for genome sequencing as well, which requires a different type of tools that are already being included in the program. So I talked about the data, and I didn't talk about the models themselves, but that's you know, a given that we need to be very careful building and evaluating these models. But more important for precision medicine to have an impact, it will have to be implemented in practice. It has to be something that results in a change in how patients are treated, and therefore a more favorable outcome at the end. So that's one thing that I think also deserves a whole lot of thinking in the part of the informatics community, because no matter how many papers we publish, if people do not use the models, then they will remain, you know, an exercise. On the other hand, if we use these models inappropriately, we might incur and do some harm, as many papers in AI fairness or AI lack of fairness have been published lately, right? So if you have training sets that come from a certain population that doesn't represent everybody, you are most certainly building models that only serve that training set population and not the population at large. When articles get published and people read those articles and try to implement them in their own institutions, definitely they need to be evaluated first. They couldn't just be put out there for implementation. So in terms of AI in medicine, I'll give an example here. Acute kidney injury, which is a major cause of morbidity and mortality. Predicting AKI is not trivial. Hospitalizations are very different. Quality of care can be a factor. And genetic and other factors may predispose patients for AKI. But many predictive models exist, both for acute and chronic kidney injury. Most are not deep, most are not deep learning or AI, most are regression models. So this issue of representation in models has been always there. Algorithmic bias has always been there, but somehow it only got popular now with AI for some reason. So we need to think about that. And how these models are evaluated is something that you, as the person who is making the decision to implement or not, need to think about. You know, are these performance metrics in my population sufficiently convincing that I should implement this model? And then should I implement on a control arm basis, case control, so that we know that the model is really making a difference, or is it something else that is making a difference, right? So very, very rare that clinical trials on implementation of models are conducted. And that's very unfortunate, because if this is required of devices and medications, new drugs, why it's not required of models? So that's something to think about, and it is something that the US and the FDA have been thinking about, considering models as medical device. So another thing to think about, and again, this is a risk prediction score for AKI that has been done at UCSD. It has a reasonable performance metric, as the area under the ROC curve of being 81%. So this is typically considered reasonable and could be implemented. But when you do a calibration chart and you see the UCSD cohort and then the Mayo Clinic cohort in which was attempted validation, you can see that these dots no longer stay around the 45-degree line, which is what is expected if a system is considered calibrated. They go a little bit, well, they go well over. So you see that the estimates, the estimated probability is not the same as the actual probability. So that is a problem, right? Because you can clearly see here that if you apply the UCSD model on the Mayo Clinic, it will not work well. And even though you can publish the article in there, so the lesson here is, if you are to implement such a model, you do need to test it on your population first and see if it's performing well. Now, the risk prediction models for acute kidney injury, like I said, there are so many. These are, each row here represents a review, a systematic review of AKI models. So one of them had 75 included reports. The other one, 7, 13, and so on. So how many models are there? You just sum up that they're not mutually exclusive, but there's a lot of models out there, more than 100 models, right? And then you go and look at the columns here and look at the next to the last two columns, external validation reports on those models. There are some that have none. And risk prediction models with external validation, real validation. We tested these models. We see the performance metrics in the population where they will be used. You see how few of them there are. So this is a very important problem, because if we are to do all this precision medicine, create all these models, and then not validate in the populations, it's going to be harmful. It's not going to help. So that is something very rarely discussed, but I thought it would be very important here for two reasons. One, All of Us program is primarily a US-based program. The population is very different. As you build your own biobank and precision medicine initiative in here, it's very important that you compare notes and you say, well, you know, is it validating to our population in other regions, not only in Seoul, but in more remote regions of the country, and so on. So we all will have the kind of the same issues to consider, and this is something, again, this is not necessarily new, but because of the excitement of AI, and even because of the fear of AI not being fair, and so on has come to greater attention lately. So with that, I would say implementation at medical centers is important in convincing the clinicians that there is some value. The way you convince is by actually showing some value and validating and explaining with this model, you know, you're doing better diagnosis, you're doing better prognosis for your patients, or you are on the pharmacogenetic side avoiding the wrong dosage, initial dosage for a certain drug, warfarin, for example, or you can avoid certain medications given variants that you found for the particular patient, and so on. So all of this has to be tied to the electronic health record, has to be at the point of care while the clinician is making these decisions, right? In terms of model quality assessment, I already commented that unless you have a control group, you will never know if it was precision medicine that helped or the whole practice has been changing and therefore you had better or worse outcomes. So again, think of models the same way as you think of medications and medical devices. Will the model be reevaluated? That's the other thing. We've been using models for a long time. Have they been reevaluated to see if the so-called population drift didn't happen? You know, that we have now a different population than we had when these models were developed and initially validated. The models have an expiration date themselves. So that's another thing to think about. And then how to develop all of this infrastructure in order to regulate models in a way that it does not prevent the creativity and the development of these models by, again, a lot of different researchers. So the implementation of AI, polygenic risk scores, and other predictive model at medical centers we'll also have to address some other things about the explainability, that clinicians want certain things explained, and they can also play with the model and say, what if the patient didn't have this, or what if the patient starts taking this other drug? How does it compare? And so on. So we need to get some aspect of that available. How to evaluate the model predictions, very important. If I say there is a 30% chance that this patient will develop a particular condition, how do I follow up a cohort of them and see that that 30% was actually accurate? How to explain the models, how to update the models. So there is the excitement thing is that there's so many things to do that we have, like I said, PhD thesis for any student that you want to work with. But what you need to also insert in the minds of students is that you're doing this for a purpose, right? You're developing a new algorithm or developing a new evaluation method because this will matter. This won't matter in the way precision medicine is implemented, or if precision medicine will even fail because it wasn't evaluated correctly, because we didn't spend the time to convince the clinicians and the patients that this is an important initiative. So informatics and data science for precision medicine will depend on a lot of things, and then part of it is technology to enhance what is currently we do already have, to monitor and update these models frequently, and also capacity building and developing and training people with core competencies that they're currently in many, many different areas. So we in medical informatics have core competencies that are required of engineers, of computer scientists, of clinicians, and of data scientists. So what is really core in our training programs, and how do we develop people who think critically about all these algorithms and methods and everything that we do is something that is a huge responsibility. We need to train individuals at these intersections. And again, it's very exciting to me that see that the Korean Society of Medical Informatics is growing, and the meeting is having more and more participants every year. I think it's very exciting. That's a trend also in the United States with the American Medical Informatics Association. And another exciting point is that bioinformatics and medical informatics are no longer two different disciplines. And precisely with precision medicine is where we combine these two things, and we can make use of everything that we're trying to get data for so many years, and now we finally have it. We finally have those data. What are we going to do with it? So I want to say also that think about having diverse teams, because there's, you know, it's shown that the more diverse the team is, the more diverse and creative ideas come out of this team. And it's important to have different educational backgrounds, life experiences, race, ethnicity, gender identity, disabilities, socioeconomics, nationalities, language, and culture. So with that, I would say, remember my diagram, it has just all of us in Million Veterans programs. I think increasingly it should have precision medicine programs of other nations as well. And again, with no threat to autonomy or to anything, if you do maintain data locally and compute with these other programs. And I think that will be the trend. It's certainly the case with our European colleagues who are under GDPR and some other regulations, and could certainly be the same with your own initiative here. All participant data stay in their compute enclaves. You control what can be computed or not. And at the same time, you have the power of numbers, because we're dealing with so many variables in here that we need to have millions and millions of patients. And I used to joke, you know, one civilization won't be enough. We need to have several, because we're talking about, you know, so many variants in so many genes, and then the combinations of social and other determinants of health. So with that, I want to thank the agencies and the teams that have collaborated to so many of the programs in here. I want to do a shout out for our colleagues in here, in particular Dr. Hyun-Hee Kim, who has collaborated with so many of these projects while we were in San Diego. Dr. Yuran Park, who's also currently collaborating with my colleague Ji-Hoon Kim, who is also very interested in genomic applications. He's starting as faculty in our unit this year. And with that, I think we have a few minutes for questions. Thank you so much.